Welcome to our Building Bridges to the Community lecture series. Today we have a really great session, which should be really useful to you. It is called Cardiac Testing 101, because we understand that there are so many different cardiac tests out there, different recommendations. Some have radiation, some do not, some are invasive, some are not, and it's really confusing. So we have invited the Director of Cardiac Telemetry from Staten Island University, Dr. Samantha Lee, to join us. She's going to give us an overview of a number of the different tests, but she specifically requested that you join this discussion and provide questions for her and for us to answer. So, she's going to get started. She'll explain a lot of the different tests, but please go ahead and put in to the Q&A or into the chat any questions that you have. We definitely want to answer whatever questions you have out there. All right, we'll look forward to your talk, Samantha.
Thank you, Dr. Giannos. So my name is Samantha Lee. I work at Staten Island University Hospital, and I'm a cardiologist. And the first thing that people always ask is like, do I do surgeries? Which I don't. A cardiologist is someone who basically can diagnose different heart conditions, can help you treat them. And sometimes if you do need surgery, we will help kind of set you up with the surgeons themselves. And so just to give you a little bit of background, I'm working in Staten Island, and Dr. Giannos has partnered with me as part of the Cath Institute as well. And so we all work in kind of this blanket system called Northwell. And it's really appropriate because Cath is kind of this institute focused on women's health. And this conversation is not just for women, so it's for people who identify as any gender. But if you are a woman, I would write down Cath Institute, because if you're ever looking for a doctor, OB-GYN, endocrine, anyone, they kind of have a very nice list of doctors that have a special lean towards women's health in all the different fields. And so for today, we're going to be talking about cardiac testing. It's a little bit of a challenging topic. It's a little bit confusing. And so this isn't meant to give you kind of all the information, but it's meant to give you a little bit of basis. Basically, in this talk, we're going to try to figure out a few things together. And as we're going through it, I want to make sure you know where your question and answer kind of button is. It's on the bottom of your screen. So if you look at the bottom, if you have any questions during this talk, please put them in the little box. And Dr. Giannos, feel free to interject throughout the talk. We want to make sure that this is a little bit more interactive. And so keeping in mind that we're not your doctors, but we're totally here to answer any general questions you have about testing. And what we're going to try to learn during this next 35 minutes or so is what the different tests are to figure out why you're having chest pain or to figure out if you have heart disease. We're going to look at tests that visualize the plaque, meaning the buildup of stuff in your arteries. And we're also going to look at tests that look for abnormal blood flow. And then we're also going to figure out how we can look for early plaque. And that gives us the advantage because it lets us start to treat you with medications. It lets us focus on diet and exercise so that hopefully in your future, you don't have a heart attack or other heart conditions that can be caused by these blockages. And in order to talk about testing, we need to understand what heart disease is. And heart disease is obviously a very blanket term. It's just any disease affecting your heart. And it can be problems with the rhythm. It could be the electricity in your heart. It could be problems with the pump function of your heart. And so heart disease isn't really a term that your cardiologist will use. But when people in general talk about heart disease, when someone says, oh, heart disease runs in my family, what they're normally talking about is called coronary artery disease. And that's when there's buildup of plaque in the blood vessels that surround your heart. And so if you're looking here on the screen, you should be able to see my mouse. This is an artery. You can see this nice oval shape, and you can see that there's something inside of it, and that's a plaque. There's clearly this kind of cap on the plaque, this fibrous layer, and then underneath that fibrous layer, there's all sorts of junk, and that can be fat, cholesterol, it can be calcium, and it can be a buildup of cells. And so when you're looking at the drawing, if you have a totally normal artery, right, it's nice and round, and clearly the blood can easily flow through it. But if you have this artery that has a bunch of plaque buildup, you're going to get some abnormal blood flow in that really tight area, in that really narrowed area of the artery. And so when people say heart disease, even though it can mean a bunch of different things, they're often talking about coronary artery disease or these plaques. And when people say heart attack, that's because something has happened to the plaque. And so what happens is that thick kind of fibrous cap, that layer that keeps all the junk in, it's burst, it's ruptured, there's a break in it. And that allows a clot to start forming. And if you see here, it's not necessarily the biggest plaques that rupture. A plaque can be only blocking 30, 40, 50%, and it can still cause you to have a heart attack. It's really just when that plaque becomes unstable and bursts, and that's what causes the heart attack. And as the clot forms, it will block the blood flow to the rest of the heart. So you can see here in this picture that this is a blocked artery, there's a clot in it, and this kind of dusky area below is the heart muscle that's not getting oxygen, it's not getting nutrients, it's the area of the heart that's really dying because of a heart attack. And so clearly, we're trying to avoid this. And so we're going to talk about some of the goals of cardiac testing. And so I want you to take a moment. You can either write it in the chat or the Q&A, or you can just think about it on your own. Like, why might you want to get a cardiac test? Why might you go to your cardiologist and say, I think I need a test. I think I need a stress test. I think I need to look at my arteries. Now, I've listed a few reasons. One of them is to find blockages early on, right? Because if we can find them when they're small, when they're only mild or moderate, that's really where, for instance, Dr. Giannos comes in. She can help you build in, different lifestyle changes. She can help you work on your exercise, on your diet, and she can give you medications that help stabilize that plaque. And what that looks like is this photo, all right? And this is from Dr. Reynolds. Basically, on the left, you have a raw egg. That's an unstable plaque. And when that shell, that cap, holding in all of the plaque, bursts, the plaque becomes a huge mess, and that's a heart attack. But if you're able to use medicines and diet and exercise, you can stabilize the plaque. You can change it. You can hard boil the egg. And that way, if the shell or the cap breaks, you don't have a huge heart attack. It stays contained. And so that's one of the benefits of testing, is we can find these blockages early, and we can help make sure that those blockages won't lead to heart attacks in the future.
Yeah, thank you for providing that explanation. I love that slide and that analogy, just because, it's so interesting. There's a very famous example of a newscaster, Tim Russert, who had a normal stress test and sadly died a week later. And for many, many people, it's like, why could I possibly have a normal stress test and still be at risk? And it's exactly this. It's, you might not have a decrease in blood flow, which we're going to get to later. But if you even have a tiny amount of plaque in that artery, this soft, mushy cholesterol stuff that breaks off, you still are at risk of getting a clot and having a heart attack. So thank you for walking us through that. That's great.
And then another reason why you might get a stress test or a cardiac test of any sort is to find when there's a lot of plaque, right? And when there's a lot of plaque, that's what you often hear about stents, all right? And one of the things patients often ask is, can you just go in there and suck it out? Can you just go into my artery and vacuum it all out and rotor-rooter it and get rid of it? And the answer is we don't. What we can do is we can put a stent in. But as you can see in these pictures, the stent doesn't get rid of the plaque, it kind of just smushes it up against the wall. So it's still there, but we've kind of modified it. We've changed it so that you can get better blood flow. And putting a stent in is a kind of nice, quick fix, but there's a lot of responsibility that comes with that. There's medications you have to take every day. You have to make sure that your heart rate, your blood pressure is controlled, your cholesterol, because you want to protect that stent so you don't get a buildup of plaque again. So now that I've given you a little bit of background for what is heart disease, how does a heart attack happen, what is a plaque, we're going to talk about some of the different tests. And so I want you to kind of look at these photos or pictures on the right, the first test we're going to talk about is a coronary artery calcium score. And you can see these little dots showed up. What the coronary artery calcium score looks for is calcium in the plaque. It tries to measure how much calcium is embedded in that plaque. The next test that we can do is called a coronary computed tomography angiography. Very fancy term. We often just call it a CCTA. And what that looks at is this blue outline. All right. So if you're looking at the normal artery, the outline of where the blood flows would be a nice round circle. And when you do the CCTA, you'll see that. If there's plaque, you'll see that it's not a nice round circle. It's kind of got jagged, bumpy edges. It's not so smooth. You can actually see kind of how much the vessel is narrowed. And so that's what we're looking for when we do a CCTA. The third type of test we'll talk about today, which is a very broad category, is just a stress test. And that's really looking at the blood flow, the abnormal blood flow that goes through a narrowed artery. So we're going to start by talking about the coronary artery calcium score, which David has had. And as I said earlier, the coronary artery calcium score is going to measure the amount of calcium in the arteries surrounding your heart. And so it's going to be these little blue dots. It's going to look inside the plaque and see how much calcium there might be. And now a coronary artery calcium score, or calcium score, is really best used in patients that don't have symptoms. So we don't necessarily want to use it if you're already having chest pain and you're already complaining of symptoms when you might walk or exercise or carry the groceries. And so this test is really great, for instance, if, in my family, my dad's had a lot of stents. He also smoked for a really long time. He's not really in great shape. His dad's kind of the same, and he's had lots of stents. But my uncle, on the other hand, never smoked, never drank, exercises, is fit, right? So he doesn't have any symptoms, but he's kind of curious about his heart because it runs in his family. And so he's someone who's gotten a coronary artery calcium score. And it was good for him because the results of the test changed what he did, right? We never want to order a test just because. We want to order a test because it's going to make us think differently about our bodies and differently about the medications we take and differently about the things we put in our bodies. And so when you do the calcium score, we basically just put you through a CT machine. That little donut you're seeing, you slide right through it, and it takes images of your heart. And as you can see in this kind of middle photo, it basically takes sliced images of your heart. Your doctor sees it in kind of this black and white image, and the really, really bright white areas are the calcium. And so you can have different amounts of calcium, and your doctor will actually tally up how many bright white areas they see, and they'll give you a calcium score. And so if you're looking all the way on the left, you can see there's really no bright white dots in the heart. That's a calcium score of 0. And that's helpful information. It says right now, we don't see plaque buildup. Now, there's a caveat to this, and I will say at the very end. So if you have a calcium score of 0, it might mean continue what you're doing, come back in 5 years, and maybe we'll take another look. Whereas if you're in this middle category, you can see mild, here's a score of 29, moderate, here's a score of 250. There's a little bit of these white spots. And so that shows us that this person does have some calcium in their arteries. And if I'm seeing that person, I would say, you know what? We should really start a statin. We should start a medication that lowers your cholesterol. We should even think about aspirin. We should talk about what your eating habits are and what your exercise is. And we should kind of make improvements on those ends to help prevent you from building up more plaque in the future and to stabilize the plaque you already have. So that's for people who fall in the mild to moderate category. Now, all the way on the right, you can see there's lots of bright white. This patient has lots of calcium, and we're probably going to send them for more testing. So this is someone I might say, let's, actually do a stress test on you. Let's get you on a treadmill. Let's see how you do. Now, the caveat to our calcium score is it will only see the plaques that actually have calcium. And some people can build plaques that don't end up having any calcium. And so we just have to keep that in mind when we're interpreting the information, right? And that's not for you to kind of remember. That's something that your cardiologist is going to remember. So before we move on, any questions about the calcium score?
Yeah, I'd love to just mention something, just because many times in our practice we get asked whether or not, they've got a calcium score. It said they had a score of 150. They've been eating really well on their medicines and want to know, should I take the calcium score again? Should I go back for this test? It sounds logical that you would want to do the same test to look at progress and see if you're doing better and if it helped. Unfortunately, it's not actually useful to do the calcium score again. All it shows you is whether or not you have plaque that is calcified. So unfortunately, what happens is you could have other plaque in your arteries that is not calcified. And then just by all the healthy things you're doing and the good medications, that plaque may get calcified as a result of just stabilization. It's sort of a positive kind of effect. So although the test is good as a one-time thing to help make decisions, unless it was 0, in which case you could argue to repeat it. Even 3 to 4 years now, they're recommending you might even go back to look at it. But otherwise, no, not to track disease with it, unfortunately.
Thank you for sharing. Anyone else? We've got a lot of good information. So if you think of a question later, you can always still ask it. So the next type of test you might get is called a coronary CT angiography. And this is something that is becoming more and more common. And it's a really, really neat way of looking at the heart. And so if you remember in the little diagram, with the coronary CT angiography, we're really looking at kind of this area. We're looking at how much area does the blood flow through? Does the vessel look like a straw? Is it nice and smooth on both sides, tapering to the very end? Or is it bumpy and does it narrow in certain areas? And so this is really helpful in patients that have symptoms, and it can be used in patients that don't have symptoms. And David, I see your question. We'll make sure we answer it. And so when you're getting a coronary CT angiogram, what we first do is we give you medications. All right, we're trying to get your heart rate to be 60 beats per minute. So your doctor will say, take this pill at night, take this pill in the morning, then go for your test. When you go for the test, they'll set you up by the CT scanner again. And then they'll give you some more pills. These pills go under your tongue, and what they do is they help expand your artery so we can get better images. And then we'll also inject dye. So this weird contraption on the top right is an injector, and it basically pushes a contrast agent, pushes a dye into your IV, and so you can see how it flows in the arteries around your heart. And your doctor will get something that looks like this, all right? And to give you an idea of what that tells your doctor, you can see here on the left, this is someone who has no disease. They have nice smooth walls that taper all the way to the end. Whereas here you can see someone with moderate disease. The bright white is the blood vessel. It's the contrast inside the blood vessel. You can see it's bright white. And right here, you can see it narrows, it tapers. You can see there's a little chunk eaten out of it, and that's the plaque. And then after the plaque, it gets wide again and it looks okay. But right here, we might be worried about that stenosis, that plaque, that blockage. If you're looking all the way on the right, this is someone who has severe disease. And as you can see, you have the blood vessel and it tapers to almost this thin little string. And so that's someone who I wouldn't be surprised if they were having chest pain. And so in this test, we're actually looking at the arteries. But it's really important to understand that we're seeing the arteries, but it doesn't mean we know how that image correlates to your symptoms, right? So someone can have moderate blockages and feel totally fine. Or someone can have moderate blockages and feel pain when they're exerting themselves. Or someone can have moderate blockages and they could have reflux. But, we don't know if that symptom is related to this blockage or not. It's probably not if it's reflux, right? So it's hard because sometimes we don't know if the patient is, having some sort of symptom and if it relates to the images we're seeing. And so once again, we just have to know what we're getting images of, what information we're getting, and how that might change our decision making. So I'm going to take a pause here. Think of your questions about coronary CT angiogram. And then David is asking, what will the effects of statins be on a calcium score? And I think that's kind of what Dr. Giannis was talking about, is that sometimes actually plaques that have a lot of calcium might be more stable. And so statins can increase a calcium score, but it doesn't mean that your disease is worse in any way. It might mean that your disease is okay. In fact, it might mean your disease is better because it's stabilized. And so that's why once we decide you have a calcium score that's not 0, it's not helpful to go back and look again. It might be helpful to get a coronary CT angiogram in the future, depending on if you're having symptoms or what's going on. But it wouldn't be helpful to do the calcium score a second time. All right, so we talked about a calcium score, which is just looking at how much calcium is around your heart. We talked about the coronary CT angiography, which is using contrast to see inside the blood vessels, how wide the blood vessels are. And now we're going to talk about the broad topic of a stress test. And so Agnes has had a stress test before, David has had a stress test before. And so it's a very, very, very broad term. But what we're looking for in any of the stress tests is to see how much blood flow your heart gets when it's working hard. We're trying to see how much oxygen your heart's getting when it is pumping really hard or when it's stressed in some way. And it can be used for patients who have symptoms, or it can be used to figure out if patients have heart disease in the first place. And so here, as you see, we're looking for that abnormal blood flow. Now, stress tests have different components. Every stress test, you're going to stress your heart in some way. And that might be exercise. So Agnes, just like you exercise it on a treadmill, that might be the stress. Or sometimes people can't exercise. Maybe they have bad arthritis of the knee, or they have sciatica. Those patients can receive medications, right? We can give them medicines that will basically simulate the effects of exercise on the heart, or medications that will stress the heart in some other way. Every stress test, you get an EKG, an electrocardiogram, and that's when they put those little stickers on you and they measure your heart rhythm. So every stress test has the ECG component. And then your doctor might decide they want additional imaging. They don't always need to have it. That's why there's a plus minus sign. But if we do get additional imaging, it might be an echo, which is when we use ultrasound waves to see your heart. Or it might be a nuclear stress test. And that's when we give you something that's actually radioactive. And that helps us visualize your heart. And so we'll start by talking about the most basic type of stress test. And that's an exercise stress test. Now, as you can see on the bottom left, I borrowed this image from a website called Northwell Health. They have really good kind of graphics for these stress tests. And so when you're doing an exercise stress test, we put you on a treadmill and we start by having you walk. And it seems very easy at first, but then every 3 minutes, we increase the incline. It gets steeper and steeper, and we increase the speed of the treadmill. And so only a few minutes in, it'll feel like you're climbing up a very steep hill, and then it will feel like you're running up a mountain. And so it is not an easy test. But your goal is to keep on exercising on the treadmill for as long as possible, because we're trying to get your heart rate higher and higher and higher. And as your heart rate gets higher and your heart works harder, we see what happens to your heart rhythm. And we see if there's any changes in that electrocardiogram. And so that's what we're looking for in an exercise stress test. Now, if we add the ultrasound component, that's called a stress echo. And so what we do is we start by using the ultrasound to get images of your heart. And that's images of your heart when you're resting, when you're not doing anything at all, you're just lying there in bed. And then we put you on a treadmill. And when your heart's going as fast as possible, we take another set of images on your heart and we compare them and we see if there's any difference. Now, as I said, some people can't always walk on the treadmill, and that's okay. We can give medications to kind of make your heart beat faster and harder. And that might be called a dobutamine stress test, for instance. And so in the next slide, I have, some video of what your doctor's looking for when they do a stress echo. So just to orient you a little, actually, let me pause it. You can see this is a little donut, this circle. If you imagine your heart as kind of a cylinder, like a cylinder basket, this is looking at it right down the barrel. And so this white circle is your heart muscle. And if your heart muscle is beating, it's going to come in towards the center of the circle. It's contracting. And so basically you'll see that all of the muscle comes in closer to my pointer. So you can see my pointer, there's 2 pointers on screen, but you can see how all of the heart muscle is coming in towards the center, it's contracting. And so this is normal at rest. Now in this patient, when they went on the treadmill, we took another set of images and you can see only the bottom part is coming up towards my mouse, right? This whole top part isn't moving as much. And that's because the top part is starving for oxygen and nutrients. The top part isn't getting good blood flow. And so here, the images look different. This is a worrisome study. This is positive. It's abnormal. It makes me think that this person might have a blockage in one of his or her arteries. And so this is what your doctor's looking at, your cardiologist is looking at when they order a stress echo. I'm going to let this play because I think these images are really cool. And Dr. Giannis, do you have anything to add about this portion of exercise or stress echoes before we move on to nuclear stress tests?
Your images are amazing, I have to say. Really, really nice pictures, and they highlight some really key things. So that prior one showing the CT angiogram really shows anatomy, as you pointed out. So we're understanding exactly what the vessel looks like on that. Whereas here, you're sort of seeing the effects of what we call a functional test, where we're seeing the effects of decreased blood flow on the muscle, where without enough blood flow, that muscle just cannot move in that specific region. So they're really different things. It's great that nowadays we have all kinds of different tests that we can use. It's almost a little bit challenging because, figuring out which test is the most ideal for each patient at a given time point is, quite complex. But no, these are amazing images. And, I guess I'd love to know how you tease out, and you may be getting to this anyway, how you decide between these tests in terms of CT angiogram versus the stress test.
Yeah. So I can elaborate on that a little bit towards the end. I don't have specific slides, but we can just kind of have a discussion of who might be better for one test versus another. Perfect. Now, before we get to that, I want to mention the nuclear stress test. And this is kind of what's most commonly used. So when someone says they've had a stress test, this is often what they're referring to in my experience. And what happens with this is, first, you get an injection of a radioactive tracer, which means it's a little bit of radiation. And basically that tracer goes wherever the blood goes, and it reaches whatever parts of your heart that the blood flow is reaching. And we do that first when you're resting and relaxing. And then we make you exercise. And when your heart is beating at its fastest, we give you another dose of the tracer. And so in this test, once again, if you can't exercise, we have another option. And what the images look like is we basically see where the tracer has gone in your heart, right? So if you remember, we're looking kind of down the barrel, down the cylinder. So this should look like a bright orange donut, but you can see we're only seeing a C shape of orange, and that's where the blood flow has gone. And this area that's missing hasn't gotten blood, right? So that's an area of reduced blood flow because there's probably some sort of blockage. And so what your doctor looks at during a nuclear stress test is all these images. And I remember when I was learning how to read nuclear stress tests that this looked crazy to me. It just looked like rainbow donuts, and I couldn't see anything. But if you look here on this second row, these are what we call rest images, right? And you see that it looks like orange donuts, right? All of them look pretty round. But if you look at the top row, this is the same patient who has been stressed. You'll see the orange is really only on the bottom part, and the top part is very purple, right? It means that the top part hasn't received as much tracer because that heart muscle has reduced blood flow. And so this is also a functional study, like Dr. Giannis was saying, where basically we're seeing the effects of blood flow on the heart. And so when you say stress test, there's different things you can be talking about. It could be an exercise stress test where you just run on a treadmill, nothing else. It could be a stress echo where we add on these ultrasound images of your heart. Or it can be a nuclear stress test where we give you some sort of radiation dose to take a look at where the blood flows when your heart's at rest and when your heart's been stressed. And as we've been kind of alluding to, there are these anatomic versus functional studies, right? So functional means I'm seeing what happens to your body when you are stressed. I'm making you run on a treadmill, or I'm giving you a medication to simulate exercise. And so with a functional study, I'm really seeing how your body responds, right? How the blood flow changes when your heart is under stress. And examples of functional studies are all the 3 different types of stress tests we talked about. When we talk about anatomic studies, that's when we're actually just looking at what the blood vessels look like. You know, there's no way for me to relate to the symptoms you're having, but I can say, wow, this artery has no blockages and this artery has an 80% blockage. It gives me kind of a number for how severe of a blockage there is. And so there are many options, right? If you go to your doctor and say, hey, I want to know if I have heart disease, I want to test. There are many different types of cardiac testing. And what your doctor decides will really depend on your symptoms or maybe your lack of symptoms. Your doctor is going to figure out why you need the test, right? Do you need the test because you're having a surgery? Do you need the test because heart disease runs in your family? Do you need the test because you're having some symptoms? If you're having some symptoms, your doctor's going to say, ask you a ton of questions and try to figure out, are your symptoms likely to be the heart? Or are your symptoms less likely to be the heart? And that's going to inform your doctor's decision on what test to perform. We need to know if you can exercise. We need to know what your regular EKG looks like when you're not on a treadmill. We need to know all your medical history. And sometimes we need to know about your body, right? If you have large breasts, I might not be able to use an echo. The ultrasound might not get all the way to your heart and back. And so each of these factors are going to play into what your doctor decides to order. Dr. Giannis, do you want to talk a little bit about what factors you think about when you're deciding on a cardiac test for your patients?
Sure. And, this is challenging nowadays. I'm sometimes torn, there's benefits to each one. And sometimes, you have a hard time deciding. So one important thing I think is in a person who does not yet have a diagnosis of coronary artery disease, who essentially is not yet on the appropriate preventive therapies, who comes to me with symptoms that may be related to heart disease. Our go-to test used to be, you have symptoms, you're having chest pain, we'll get you a stress test to start with. And nowadays, we are, based on our guidelines, also able to order a CAT scan, a CT angiogram. And the added benefit there, I think, is that even if that patient does not have a decrease in blood flow and they would have had a negative stress test, they may very well have tiny amounts of plaque throughout the arteries that would not have been diagnosed otherwise. And learning that information then dictates the fact that they'll probably be put on a statin, a cholesterol lowering agent, and possibly aspirin. So it definitely can guide treatment a little bit more in that patient that doesn't have a diagnosis already. It's a little more challenging, to decide somebody who already has disease. I might potentially go for that stress test, because if we're already doing everything optimally, we just want to know, do those symptoms have to do with a narrowing, in which case it might be useful. But I love the way you explain each of the different ones and the limitations that we have to deal with in choosing.
And I think it's really important to talk about, what happens when there is some abnormal finding. Because as you were saying, for some people, you might choose the coronary CT angiogram. For some people, you might choose the stress test. But I think what's interesting is if you get a positive test, we might then swap. So as an example, for some patients, if we see a narrowing, Dr. Giannis was saying, if it's very mild, we might say, great, we now know that this person has a plaque. We know that they have heart disease, and we can treat them with medications we normally would not have started. This is excellent information because now we can practice preventative medicine. But say we do the CT angiography and we actually find that they have more moderate or severe plaque, but their symptoms are, not so obvious. They might not be related to the heart. For that patient, I might say, now let's do a stress test. We got the anatomic study. Let's do a functional study. Or sometimes if patients get a functional study, there's something called a false positive, meaning it looks like it's abnormal, but it could be just an error. It could be the way that the patient's body fat is distributed. It could be the positioning when we did the CT. It could be the algorithms that the computer uses to produce the images. And so if I think maybe it's a false positive, I don't really think this patient has classic symptoms, I might take that person who already had a functional study and do an anatomic study and do a coronary CT angiogram. Or if I'm actually really worried about the patient, that's when I'll send them for a cardiac catheterization. And so cardiac catheterization is sometimes called a cath or an angiogram, a left heart cath. You'll hear it by many different names, but it's the procedure where we basically put a very, very large IV in your wrist or your leg. And don't worry, you're in a twilight zone for this. We pass kind of cables and wires up through your arm towards your heart. And when we're close to your heart, we inject a dye. And that dye lets us see the arteries. It's an anatomic study. We can visualize the arteries. We can see if there's any narrowing of the arteries. But in the cardiac catheterization, it's invasive. We're already inside the blood vessel. And so we can actually go in and put a stent if there's a very, very significant blockage. And so it's an invasive procedure. It lets us visualize the blockages. And if there's some sort of significant plaque, we can actually widen the artery by opening a balloon. And then we can put a stent in to kind of keep the artery open and allow for more normal blood flow through that artery. And so these were some of our objectives. As I said, it's a really big and broad topic. And so it's not something that you're supposed to leave here with a complete understanding of. But what I really want you to know is that there's many ways for us to figure out why you might be having chest pain. There's many ways to figure out if you have plaque. We can do a calcium score. We can do a CT angiogram. We can do a catheterization. All of those things will let us see plaque. And there's also different ways of letting us look at if there's abnormal blood flow when your heart is stressed. And those are the stress tests, the functional studies. And in many patients, there's a lot of benefit of finding the plaque early, right? It's important to do a calcium score and find the people that have that kind of mild to moderate range. It's important to do a coronary CT angiogram and find the people that have only a slight narrowing, because those are the people that we can really target and say, hey, you need to focus on your diet, your exercise. You really need to take these cholesterol lowering medications because we want you to live a long and full life. We don't want you having heart attacks. We don't want you having heart failure. We want to protect your heart as much as possible. So thanks for joining. I do want you to ask any questions that you have. I see one popping up. So David is asking, going back to the coronary CT angiogram, what's the value learned? And what's the next step? So that is a great question. And it very much depends. So if you are having symptoms that make me think I'm worried about a blockage, right? This might not be the test that I order, but say someone else ordered it and it shows that you do in fact have a severe blockage. Then I would say, let's do a cardiac catheterization. Let's get inside your vessel. Let's see how bad that blockage is and let's open it up because it seems like you're having some symptoms. All right. Or if it's in one of your blood vessels that isn't the major blood vessel, I might say, I'm worried about your symptoms. I'm looking at this. It seems like you might have a severe blockage. You're not on any medications yet. Let's start all the right medications for your heart and see if your symptoms go away. And if your symptoms go away, we can say, great, we'll continue to monitor this. Maybe we'll get a stress test in the future. And if your symptoms don't go away, then I might say, it's time for that cardiac catheterization. So that's someone who might have some severe narrowing on their CCTA. If you have nothing on your CCTA, if you have the arteries of a newborn baby and they look perfect, I'm going to say, whatever you're doing a great job. Keep up with it. Come back to me if you have new symptoms. Or if you're in that middle area, that Goldilocks, that gray area where you have kind of mild or moderate disease, I'm going to say, you know what? It's great we got this test. Because if we did a functional test, if we did a stress test, I would never know about this, right? These little plaques are not enough to cause abnormal blood flow. So these little plaques would be invisible on the stress test. But now that I can see them on the CCTA, it's awesome that I know they're there because now we can give you a statin. We can talk about your diet. You can start doing 150 minutes of moderate intensity activity per week. And maybe we can even start an aspirin. And so if you fall into any one of those categories, the CCTA gives me a lot of information. And so that's when I mentioned it. I said, it's really cool because it's not something that we were really using that often 10 years ago. I think, it wasn't on anyone's radar. And now it's something that is actually one of our first line. It's kind of the preferable study for many situations. And so it's something that's becoming more and more common. Whereas only a decade ago, it wasn't something we had in our tool belt.
That's exactly right. We're really using it quite a bit. And I do think that it is going to save a lot of lives downstream because you're recognizing the disease process early before you've had that heart attack or stroke. You get put on the right therapies that are going to then prevent the disease. So I do think it's an ideal modality. In addition, we have, fortunately at Northwell, quite a bit of what we call FFR, or functional flow reserve is what they call it. It's just essentially, aside from just looking at the anatomy and the narrowing, you also have the ability to determine whether the blood flow is compromised, which is huge because that's kind of combining your stress test with your angiogram. It's giving you both what is my anatomy and is there a decrease in blood flow in this area. So really, really helpful information. And one interesting thing, I think, we're not there yet, but I think that eventually many people feel that we may get to a point where we're using that CAT scan to guide our therapy, like how well are we doing, sequentially monitoring over time. And I think that is something that patients are always interested in seeing, like, all right, I'm doing all this stuff. How is my plaque? Is it getting better? Is it improving? At some point in the future, we may get to that point where we'll be able to sort of look and say, you know what, we are doing everything correctly. You're stable, you're decreasing, et cetera. But not yet. We're not there yet. So that might be in the future. And you work on the inpatient side predominantly. So we're sort of in a slightly different world. So I'm curious, Samantha, with respect to, the preferred test when you have a patient coming in to the hospital with chest pain, how frequently do you feel like that is something that you go to?
So so just to give everyone an understanding of the hospital, because it's very confusing if you're a patient and don't work in healthcare. When you come in through the emergency room, you're seen by the emergency room doctors. And they basically say, you're safe to go home, or we think you need to stay in the hospital. And they also have this kind of in-between option that's, you know what, let's keep you in the emergency room for 24, 48 hours and do a few tests before we really make up our mind. And that's called the observation unit. And so many people that I see actually already got the test because some other doctor has already ordered it, right? They were in the observation unit in this kind of 24, 48 hour kind of layover in the hospital. And so it's really the emergency room doctors that are ordering a lot of these tests. And they order a lot of CCTAs, which is really neat. They have a whole protocol. They get the patient's heart rate where it needs to be, and then they'll order a CCTA. And so as a cardiologist, we don't even see a lot of these patients. They might say, everything looks good, go home. And this patient might never see a cardiologist. But when the patient does have a little bit of disease, that's when they bring us on board. And sometimes it's the patient who just falls in that mild to moderate range. And we say, you don't need to stay here. Let's get you on those medications. Let's send you home. We'll see you in the clinic. And right, so it saves a lot of time because we've quantified how much of a narrowing they have of their artery. And then there's the patients that might have very severe blockages. And that's really when I come into play. And I'll go and I'll see the patient. And what I do is I actually just talk to the patient, right? And I really get a good story. And if the patient is telling me all the things that kind of raise my alarm bells, if the patient's saying, oh, I walk a block, it feels like there's a brick sitting on my chest, it hurts so much. I used to be able to walk 2 blocks, but now it's 1 block. And today it was only to the edge of the street. You're going for catheterization. But there are some people that tell me things that I say, you know what? This doesn't really sound actually like the heart. They might say, I eat a really spicy meal and then I get this burning pain. And I said, that really sounds a lot like you have reflux. And so this finding of a severe blockage might just be true and unrelated. And so when I get that sense of feeling from the patient, I might do a stress test, right? Something that's not invasive, something where we're not actually poking into the blood vessel, because with anything we do, there's always a risk of harm. And if I don't need to, put catheters and wires up your vessels and expose you to a very, very small risk, but a risk of stroke or bleeding or damage to any of those vessels, then I'm not going to. And so that's kind of what I do is I spend a lot of time talking to the patients and just hearing what their story is before I make a decision.
That's such an important point. Sometimes in medicine, we can do various tests and we will come up with multiple random findings. You do a CAT scan and they incidentally noted this, little thing in this area and this, and you can end up treating a million different things that will do you absolutely no good. So I think it's so important to, remind us that the clinical story, what your symptoms sound like, whether they're concerning, whether they're consistent with some kind of pathology is actually still really, really important. Even though we have all this testing and all these fabulous little areas, we really have to rely on, and that's why it's really important to get connected to a good clinician and somebody who you trust and you can get your story to, because if you're doing this on your own and you Google and you try to find the solutions, it's quite complicated. So definitely agree that the clinical story that you're getting from your patient is actually extremely important.
So I skipped to the end of some of these fun questions I had. And this is hopefully a very obvious answer to all of you. But basically the question is, why is it important to figure out if you have coronary artery disease in its early stages? And you can certainly type your answers into the chat, but I'm hoping that everyone knows it's really all of the above. And so the reason why it's important to use things like the calcium score and to use things like the CCTA is because we can find this early disease. And as we've been talking about, it allows us to start the right medications. It allows us to focus on your diet and increase your intake of vegetables, fruits, whole grains, choosing fish over red meat. And it allows us to, it's a motivating factor. If you know that you have heart disease, it's a lot easier to get yourself up and get to the gym or go on a brisk walk when you know that you're really working towards a goal of protecting your body and your health.
It's great advice, actually, because like you said, anytime you do a test, you're doing it for a reason. Hopefully it's going to change something that you're doing. And I would argue that whether you have disease or not, for B and C, those are universally required from all human beings. Eating your vegetables, your fruits, and getting the exercise in, great. And this is a wonderful overview. This is going to be recorded. We will share it with you again, but I think, it is a confusing topic. Even cardiologists are grappling with which test to go with at times, just because we have so many good options. So this has been a great overview, making it really simple as to what to expect from each one, what the benefits and the cons of each are. So thank you so much for sharing with us.
Thank you for having me. Thank you guys for joining. And for those of you who participated and shared your experiences, thank you so much for being part of the talk.